associate professor in residence in the Department of Emergency Medicine at UCLA. And her work is really focused on actually multiple different things around equity for people accessing healthcare services, including work on low barrier substance use access, patients who are trying to access treatment for, things like asthma, substance use, ways of implementing harm reduction services, low barrier care, and lots of other things. But we asked her to speak to us specifically about equity in substance use research and treatment access. And so I'm really excited to introduce her and welcome her to the Penn Camp Speaker Series. So thank you, Liz.
Thanks for having me. As I told Jean Marie in the email, I hope I can do the title of this talk justice. And I also want to thank Dr. Kadri. Some of this content in the talk today, we have been working on together for a different webinar that we're going to be doing together. So I'm glad you can join. Let me know if this looks okay. Are we on regular view?
Yes.
Okay,
Yes.
fantastic.
Perfect.
So just start with a couple of disclosures. I am partially funded by a CDC grant, although that has nothing really to do with the content of this talk, and I have no commercial conflicts of interest to disclose. Today, I'm going to talk a little bit about federal drug policy and how it exacerbates addiction treatment and overdose inequities, talk about a social emergency medicine approach to emergency department patients with substance use disorders, try to understand the role of the emergency department, both harm reduction and role of the emergency department, It's echoing.
Try that again.
I think the echo is gone.
Yeah.
Okay. Understand the role of emergency department harm reduction and treatment initiation and preventing overdose deaths and addressing gaps in treatment access, and talk about a couple of strategies that I worked on in Rhode Island to try to improve engagement and linkage to care and address treatment inequities. So overdose deaths, I think this group is familiar with this. You don't need me to go through all of the different waves of the overdose epidemic, but as we know, nationally, overdose deaths are rising, but they're not rising at the same rate in all different communities and all different locations. Overdose death rates are increasing at a faster rate among Black, Native American, and Hispanic communities, particularly among men in those communities. And when we talk about interventions, most of the time we're really focused up here on clinical interventions. So this is the health impact pyramid. Some of you may have seen this before. This is a way to conceptualize the degree of where your interventions act in terms of producing individual health benefit or population health benefit, and how much effort on both population level or individual effort those interventions entail. So socioeconomic factors, those have the largest population health impact. And these are about institutions, environment, social determinants of health, and then clinical interventions and counseling education. These are really focused on individuals and utilizing our tools and techniques of addressing addiction as a chronic disease, both overdose prevention and response efforts, which we're going to really focus on in the latter part of the talk today. Another way to kind of think about types of interventions to improve individual and community outcomes for people who have substance use disorders is the socio-ecological model. You may have seen a model like this before as well. These are kind of nested levels at which interventions can have both individual and population health impacts. So individuals on the interventions on the left side of the screen are individual and interpersonal. These are more about case management, services programs, naloxone distribution, addiction treatment, counseling, organizational type interventions to help improve outcomes for folks with substance use disorders, and as well individuals and then also population-wide, include bridge programs, referral networks, employment practices, job programs for people with substance use disorders, provision of trauma-informed care on a system-wide level. And then there's also community and policy type interventions. So these have to do with some more structural determinants of health, like transportation, housing, and then policies related that shape our community's social determinants of health, like presence of affordable housing, drug criminalization, insurance coverage, education, employment benefits, employment access, etc. And the interventions we design can function in both downstream, midstream, and upstream. So upstream interventions are really focused on laws and policies that shape community conditions. Midstream interventions focus on addressing individuals' social needs, and then downstream interventions focus on individuals' health outcomes. First, I want to talk primarily about upstream and midstream interventions that have to do with more social determinants of health and health-related social needs. So the drug supply.
Start with a brief discussion about the drug supply.
Overdose deaths, as we already talked about, are rising nationwide. Many of these deaths, sorry, let me back up for a second. When we look at the rise of overdose deaths, starting in the third wave in particular, we see a rise in deaths related to synthetic opioid overdoses. So in Philadelphia, you are all very well familiar with fentanyl-related deaths. Now, California, where I live now, fentanyl is somewhat still new to individuals out here, but in Rhode Island, where I worked before, we had fentanyl in the drug supply since 2014, somewhat similar to Philadelphia. And this was a main driver of overdose deaths. We see a increase in presence of opioids in the stimulant drug supply as well, which is a main driver of many overdose deaths among people who use stimulants. So this is a figure that's looking at rise of stimulant-related deaths. The yellow line is an increase in deaths with stimulants with synthetic opioids other than methadone, often fentanyl. And you see a sharp rise. You see an increase starting in 2016, 2017, but a sharp rise starting in 2019. So, the drug supply itself is unpredictable. It is increasingly potent, and it is deadly. Since the 1970s, the U.S. has taken a primarily criminal justice approach to substance use and substance use disorders. In 1971, the war on drugs was declared, and in 1984, the Sentencing Reform Act was passed, which tried to increase consistency in the United States of federal sentencing and established such policies as determinant sentencing, three strikes laws, mandatory minimums. And altogether, these policies have led to an explosion in the U.S. prison population. The U.S. composes about 5% of the world population, but about a quarter of the world's prison people, a quarter of the people who are incarcerated. And about 1 in 5 people who are incarcerated for a drug-related offense. Most of these are possession-related offenses, not offenses related to sale or manufacture of drugs. And despite similar patterns and proportions of substance use, there are significantly different rates of incarceration for overall in the United States, but specifically for drug-related offenses. So 1 in 9 men have a lifetime likelihood of imprisonment in the US, but for Black men, this is 1 in 3. For white men, this is 1 in 17. We also see these racial inequities among women, where 1 in 18 Black women have a lifetime likelihood of imprisonment and incarceration in the US. And drug use is slightly higher in white communities compared to Black communities, with similar percentages, racial composition among people who sell drugs, but drug-related arrests is significantly higher among Black folks compared to white folks in both state and federal and arrest, but then also actual incarceration in state and federal facilities. I think that the U.S. has taken one particular approach to use incarceration as a means, purportedly as a means to address substance use and substance use disorders. We have not seen a decline in substance use. We have not seen a decline in opioid overdose. We have not seen a decline in substance use disorders. We have seen the opposite. Now, I'm going to very, very briefly give one example of a country which has taken a radically different approach than the United States has taken it, and has had some improved outcomes in both treatment and overdose, and as well as with reductions of their prison population, and that is Portugal. So Portugal decriminalized, this is, if you have not been to Portugal, I know where it is. It is in Western Europe. Portugal decriminalized drugs to make it as, they're not legalized, just to kind of clarify the difference between decriminalized and legalized. They're still illegal to use drugs, but instead of having a mandatory prison sentence, folks can have the option of going to treatment. They can pay a fine. So in Portugal previously had an extremely high rate of opioid overdose and was kind of seen as the quote unquote heroin capital of Europe. And what they've seen is an increase, a significant increase in the number of people who are in drug treatment. So while they decriminalized, they significantly ramped up their capacity for treatment access. They have treatment vans, increased number of facilities. They knew they were going to have increased demand, and they scaled up to meet that demand. And they've had reductions in incarceration, in overdose deaths, incarcerations, and new HIV diagnoses related to injection drug use. There is one state which has chosen a similar type model, although slightly different, and which is Oregon. So in 2020, Oregon passed Measure 110 through a state election, which decriminalized personal possession of small amounts of drugs. And people would not be arrested, but could be fined or go to treatment. The fines would then be used to fund addiction treatment programs. There's a lot of attention being paid to Oregon right now about how that is going to change both treatment engagement and outcomes in Oregon. I know that there are a few different ongoing evaluations. But I think that this experiment of decriminalization in the US will be very interesting to see the results of, although they have not had the same scale up of treatment and have had a different context of fentanyl being introduced into the drug supply, which was not the case in Portugal. When we look at Portugal's data, that was before fentanyl. So it'll, with those caveats, I think it will be interesting to see how things work out with this policy experiment in Oregon. So I want to talk a little bit now, kind of shifting gears into some of the downstream level interventions. It's particularly in the emergency department. So harm reduction and treatment access. So harm reduction, which I think some of you may be familiar with. I know you had Dr. Sue come speak to you not that long ago, who is a harm reduction champion and leader, but there are several core principles that drive harm reduction work. And I think, really when I wanted to become a physician, like these also drove my reason of like wanting to be a caregiver in medicine, right? Respect for people's health and dignity, working in a person-centered way, involving the participant, the person you're caring for, in the decisions that affect their lives, recognizing inequities and injustices, respecting their individual autonomy, and being pragmatic and realistic about substance use, and trying to mitigate any harms that an individual might experience as a result of substance use. And really just focusing people's dignity and treating them with compassion and respect. And there are several interventions, some of which we do in the emergency department and some of which are more community-based. So one is naloxone distribution for prompt overdose response and reversal, syringe services programs or distribution of safe consumption equipment, fentanyl test strips, supervised consumption sites, which I know Philadelphia has had some efforts at, which have not been successful yet, but I'm going to talk a little bit about that. And then in reference to the previous conversation about the drug supply being increasingly potent and toxic, many advocates are advocating for a safe supply. An unregulated supply is a dangerous supply. The argument being a regulated safe supply could save lives, would save lives. So syringe services programs, or they provide not just sterile injection equipment, they provide equipment for safer consumption. They are both been shown to lower the likelihood of overdose deaths. They decrease risk of HIV transmission. They actually are, while they're not designed for this, they've actually been shown to increase treatment engagement and decrease drug consumption litter surrounding the sites. There is decades and decades and decades of evidence around syringe services programs. They are a recommended essential service by the World Health Organization. In many states, they are illegal in the United States. So this is in Pennsylvania, where you are. It's locally permitted. There are some places that it is not allowed, and a lot of the syringe services programs are actually operating underground or on a somewhat of an agreement basis with local authorities. And very briefly about overdose prevention centers. So there are over 120 overdose prevention centers in 10 countries. There's a variety of models. They are places where people can use previously obtained substances in a monitored setting, where people can intervene in the event of an overdose or really any kind of adverse reaction. They can be medically or peer supervised. There's stationary models, there's mobile models. They can be located in a housing type of complex. There are even hospital-based models. Some of them are integrated with existing models. So inpatient treatment, medical facility, a harm reduction program, and they provide wraparound services in connection to those resources. They are heavily researched. The sites that have been most researched are in Canada and Australia. And the evidence from these centers has shown improved treatment engagement, increase in safe use practices, that they are cost effective, feasible, acceptable, and used by people who use drugs. And there's an increase in utilization of medical and other services. And they're also associated with a decline in overdose deaths and all-cause mortality, not just of people who use the center, but like overall in the surrounding neighborhood of the center, reductions in injection-related harms, decreased syringe reuse and sharing, decreased public drug use and drug-related litter, and decrease in crime incidents surrounding the site. So there was an unsanctioned center operating in an undisclosed city in the US. This has since closed. They did not have any. There are several papers written evaluating that center, which showed no overdose deaths, reduced crime in the area surrounding the center, reductions in emergency department visits, and reductions in hospitalizations. Philadelphia Safe House, which I think you may be familiar with, was an effort to open was the first kind of more public effort in the US to open a supervised consumption center in the US that has been subject to a series of court cases and is now in the middle of an appeals process, I believe. New York City opened 2 centers, and they're actually looking to expand and open additional centers. One is a peer model, and one is a medical model. And then I don't list this here, but Rhode Island, I got to be a part of the work there before leaving. And we passed a law allowing for a pilot supervised consumption center. I got to serve on the Governor's Advisory Council for development of regulations for those centers. And there is an organization which is set to be opening one, hopefully this spring. They're finalizing their space and their staffing and their protocols, and we'll be opening one in Rhode Island under the umbrella of this state-supported pilot. So shifting a little bit to addiction treatment, many people with substance use disorders do not receive any type of formal treatment. So there's estimates, this is a little bit old, this is from 2016, but there's over 20 million people with some type of substance use disorder related to alcohol or drug use, but less than 4 million, or 1 in 5, receive any types of treatment. Most, or at least over a third of treatment happening in primary care centers, and then a little bit less than a quarter happening in specialty treatment centers. And there are many inequities, many factors which result in inequities in treatment access, engagement, and continuation. So these have to do with race, ethnicity, geography, in terms of where people live, gender, whether someone is pregnant, their income, and what type of insurance they have. And these different characteristics an individual might have can influence not only what type of treatment people can get, what referrals they receive, the availability of type of treatment, hospital, outpatient, et cetera. But then specifically for opioid use disorder, what type of medication, how long that they remain in care. Specific barriers have to do with cost, insurance, transportation, stigma, both about types of treatment themselves, as well as internalized stigma people have about themselves and having a substance use disorder, and stigma they experience as a person with a substance use disorder trying to go out and navigate and get access to services, knowledge about services. Many programs have very stringent requirements, which can be very challenging for people to meet, even when they are well-resourced, and that can really limit treatment engagement. And then just availability of providers and prescribers is a really key barrier to being able to engage in treatment. This is a study that came out in JAMA Network Open in 2020, which looked at differences in buprenorphine and methadone availability in counties by racial makeup. And what they found was that buprenorphine you had much higher county level capacity of buprenorphine in white majority counties than you did in counties that were majority people of colors, particularly majority Black. You had more access to methadone and opioid treatment programs compared to buprenorphine. So there are these ways, not only in terms of rurality and urbanicity in treatment access, it limits your ability to access certain types of treatment, but in terms of racial composition on a population level, what types of treatment are available to you. So this is actually a paper out of the University of Pennsylvania, Dr. Parental's paper, and so that's Dr. Khatri. And this looked at incidence of treatment for opioid use disorder after an ED visit for non-fatal opioid overdose. And this is among commercially insured patients. So these are patients, they do not have Medicaid, they have commercial insurance. And what they found is that people who are Hispanic and Black, and actually I believe also women in this study, were much less likely to get treatment follow-up compared to non-Hispanic white individuals, as well as men, in terms of post-ED visit visits, post-ED visit treatment engagement. And when we compare, like with thinking about the federal policy, drug policy level, and some of these treatment inequities, when we compare Black individuals and white individuals, Black individuals are much more likely than white individuals to be arrested for a drug-related charge, have longer sentencing, and have higher per capita imprisonment for drug-related charges. And they're much less likely to be initiated on medication for opioid use disorder, engage in treatment after an ED visit for an overdose. We've done some research in Rhode Island that had shown that also they're much less likely to receive behavioral counseling after an ED visit for opioid overdose. I think taking these things together, what's really important for us to understand is that how we approach substance use and how we treat our patients is a racial equity issue. And the structures that we set up need to take this into account when we're trying to improve overall population health outcomes and also reduce inequities in care and patient outcomes. So now I'm going to move on to emergency department care. Okay. So I see the role of the emergency department as threefold. So we provide excellent time-sensitive treatment and stabilization. That's one of the key things we do. You come in with a heart attack, we get you to the cath lab, you come with a stroke, you have sepsis, you come in with an overdose, reverse the overdose. We deal with acute medical emergencies, which I think some people, as medical students, sometimes think is like, oh, I thought this is what the whole ER job is going to be. It's actually a smaller part of our job. We also are an acute diagnostic center. People have abdominal pain, we don't know why. You have chest pain, we don't know why. We can provide diagnostic tests on demand when we want them to see what's causing someone's symptoms. And we are a key point of healthcare access and linkage to treatment. If someone breaks their bone, we link them to an orthopedist. They're newly pregnant, we link them to an OB. And then, similarly, we can serve all of these functions for substance use disorder. If we identify someone as a substance use disorder, we can and should be starting them on treatment and linking them to care. So the three components in ED substance use disorder care that are important to consider when we're building our systems and our programs are about prevention, harm reduction, and treatment. And this is like a kind of like learning system of healthcare model that looks at, this is specific for opioid use disorder. It's not just for all substance use disorders, but can be applied to all substance use disorders. What we see in clinical practice or what we do in clinical practice can inform policy, inform our research agenda. Research can then find evidence-based interventions or strategies, which can produce policy, and then that shapes clinical practice. And these things both mutually reinforce and drive each other, as well as quality measurement, quality improvement. And we can do these all along these different axes of prevention, harm reduction, and treatment, and with the primary goal of improving outcomes for the patients we take care of, and delivering equitable care that hopefully saves people's lives. So when we start in the emergency department,
Brief discussion about the
when we start in the emergency department, sorry, I got muted for a second. I guess I'm back. I think one of the main things when I'm like talking with residents is like really just thinking about like what your goal is when you're going to talk to someone, and what success looks like. So if you're going to go approach a patient who's there with an overdose or has a substance use disorder, and you're only going to define success as them starting on treatment that very day, you're going to be disappointed a lot of times, I think, and not get a lot of relationship building with the patient or progress with the people you're trying to engage. I think that it's very important to approach people, and I think can get a lot more buy-in and actually much more successful engagement when you're approaching them with empathy, kind of figuring out where they are, what is going on for them, and like really an offering to help. Many folks with substance use disorders have had very traumatic experiences in institutional environments, including in medical care systems. And a lot of people telling them what they should be doing and shouldn't be doing. And really, I think, have a lot of their own autonomy taken away from them. But I do think approaching individuals with trying to understand where they're coming from, how you can help them today, what their own goals are for themselves, and how you can help them meet those goals, and be, very clear with them that you want to help them, avoiding an argument with them, and trying to help build their own self-confidence, self-efficacy, that they can make even small changes today to meet those goals, I think is very important. And this is, just the concept of meeting people where they are. Our job in the ED is to keep the door open. So when they are ready to make change, when they are ready to engage in treatment, they know that we're available and are a place that they can go to engage in care, and engage in treatment. And it's really, any small change is very meaningful. I think what's hard for emergency providers is that we don't always see how those initial conversations produce work, get internalized by someone, and may lead to them making a change later. That salience of that in that encounter maybe isn't always readily apparent, but I think can be communicated to our care teams in different ways to help them, to encourage them to continue to have those types of open conversations with people. And I think understanding all of these different components is like building blocks of what is comprehensive care for people with substance use disorders. Understanding how the social determinants of health shape an individual's options, or the competing demands that they're really struggling with along with their substance use disorder. Providing medications for withdrawal addiction treatment. We can help them feel better. They don't have to feel terrible. whatever decision they make in the ED today it doesn't have to be a forever decision. We just want them to do better. We think that they can, we don't think they need to suffer going through withdrawal, and we care about them and can help them. Well, A, reduce harm to themselves, but B, also prevent a future death. Behavioral health is huge for many of the individuals we care for with substance use disorders, as well as psychosocial support. So in the ED, I think that when many programs have 4 basic components to these ends. So one is naloxone distribution and other harm reduction services, and depending on the location. Some EDs are handing out some safe injection or safe consumption equipment, which is very important for reductions in infections and safer use practices. Behavioral counseling and care navigation, which I'm going to talk a little bit more about in a minute. Buprenorphine or methadone, for that matter, in the emergency department for treatment of withdrawal and treatment initiation, and then linkage to ongoing care. I think that treatment linkage can be very challenging. Philadelphia is a little bit of a different scenario. There's a lot of resources and support to have and programs available, but even so, there is also a lot of challenges to getting people engaged in treatment and treatment access. And I'm going to talk a little bit mostly about ED peer support and telehealth as 2 strategies to try to help with linkage to outpatient care. There is the other thing that comes up often, at least mostly to me, of strategies to help with that. If someone is uninsured, or even if they're insured, because sometimes the insurance doesn't really provide very good coverage. There are coupons via GoodRx. There are drug manufacturer coupons as well for some formulations. Transportation assistance is huge if people don't have access to transportation. And then, of course, the availability of an actual provider near where they live. So I know you all have a very robust and amazing peer recovery program at Penn, so I won't belabor this, but I have had the opportunity to work on a couple of different peer recovery initiatives in Rhode Island, and I am a huge advocate for these programs. I think that they are very important for multiple reasons, but they provide individuals with strength-based support, linkage to treatment. They can provide guidance and mentorship, resource navigation. And I think often even just someone who has the time to spend with someone in the emergency department and really see and treat them with the health and dignity and humanity that they really deserve and need. So these are 3 of the community health worker peer recovery specialists that work at Rhode Island Hospital, where I used to work, that make up the substance misuse assistance response team. 2 of these individuals now work with different community health worker programs in the hospital system. But this was a program we started in 2020, which is emergency department based, dually certified community health worker peer recovery specialists that provide 2 forms of engagement, one at the time of the ED visit through something we called one-touch encounters. So this is just like resources at the time of the ED visit. And then a smaller group of people go on to like a short-term case management caseload. These are individuals with higher navigation needs, usually health-related social needs. And they provide usually around 90 days short-term case management with then linkage to community services, community organizations, other existing community health teams. And they provide harm reduction, addiction treatment, and they also, a lot of the work they're doing is really around health-related social needs. So just some very preliminary data about this program. This is from March 2021 to February 2022. They approached around 730 individuals, about 65% accepted services. 122 people went on to these short-term caseloads. These are very small caseloads because this is while it is short-term, it is very intensive short-term. This is like going to the tent where they camp and picking them up and taking them to an appointment, helping them fill out paperwork, deliver them the paperwork, driving them to places. It's very, very intensive. And then among the people, and then 350 one-touch encounters at the time of the ED visit. So a little over 80% were able to engage in addiction treatment. About 3/4 were linked to a community harm reduction organization, and just under half were provided some type of housing services. This ranges from everything from like emergency shelter, like overnight, to supportive housing, permanent supportive housing. Most of the folks that the program engages are people who are marginally housed or who are unhoused. Getting housing is just the absolute top priority for those individuals. This is a little bit of older data looking at the first several months, I guess a little bit shy of a year of program, which looked at acute care utilization, 1.8 fewer ED visits per year among people who receive SMART services, 1.3 fewer hospital admissions, and 7.8 fewer days admitted to the hospital when they were admitted. Just switch gears a little bit and talk about buprenorphine telehealth, which we initially started. I'm going to talk a little bit about it. This audio-only buprenorphine telehealth service during COVID, but has actually become a really important part of our treatment system and filling gaps in initiation and linkages to care. So before the different change in the telehealth regulations, it was really only allowed for maintenance treatment, although it had been shown comparable retention, medication maintenance or treatment continuation, and obstetric outcomes. There's differences in type of telehealth, right? There's audio, there's audio visual, but with any new intervention, you need to make sure you're not just going to further entrench existing inequities. And there are potential equity issues with what types of telehealth that we choose to adopt and implement. So particularly when it comes to rurality, many rural areas do not have access to broadband internet. And then if you're requiring audio visual telehealth that requires broadband, it requires smartphones, it requires internet. And there could be significant inequities by income, rurality, and age. And there's also some evidence looking at use of telehealth during in COVID, that individuals are much less likely to use video telehealth if they're older, Asian, Black, or Latinx, low income, female, or non-English speaking. So we started the hotline in 2020. It is telephone based. It is 24 hours a day, 7 days a week. We provide buprenorphine treatment initiation and linkage to maintenance care. We had one of our community health worker peers make a follow-up call to the individual to make sure they didn't have any issues getting the prescription, or if they need transportation assistance getting to their follow-up appointment. It's free. It's funded through a SAMHSA grant through our state. Not directly to us, but through our Department of Behavioral Health. And then there's a range of prescribers. There's a couple of emergency medicine physicians. Several of us are also board certified in addiction medicine, internal medicine, medical toxicology, and then the addiction medicine fellows rotate on the hotline as well. Our main goals were to provide low threshold buprenorphine access, utilizing principles of harm reduction, and try to fill gaps in the buprenorphine access and treatment linkages, and improve equity in our access. So how the workflow goes is the patient picks up the phone, they call the phone number, the phone number goes to a call center at our healthcare system. The healthcare system makes sure they're in the computer and calls whatever doctor or PA or NP is on the line that day, and then patches us through in real time, or we call the person back in like 30 minutes. Like, let's say I'm on call, but I'm walking the dog out there. I will call them back in about 20 minutes when I'm in front of my computer and I can open Epic and look at the EHR and think about this patient. We have the privilege of being in a healthcare system that is the largest system in Rhode Island. So most people have already been there. If they're not there, then the hospital can register them and confirm their identity. This is just an overview of the workflow. I know we don't have that much time yet, so I'll go through this very quickly. But this is a hotline for people who have opioid use disorder. We do not do methadone to buprenorphine transitions via the hotline. We assess both prior substance use treatment as well as current withdrawal, whether they've previously taken buprenorphine, provide them education about how to take the medication, both verbally on the phone, and if they have an email address, we also email it to them. We can also mail it to their house, check the PDMP. And then we usually, when they've called the person who registers them, they also schedule them for an outpatient follow-up appointment. And then so we prescribe to that appointment. Now, many people who call the hotline already have an appointment. they just want to start the medication before they're able to get into care. And maybe they didn't get an appointment for another 1 to 2 weeks. So we will prescribe for them as like a gap filler, like a true telebridge until they get to their already scheduled appointment. So after we do the patient encounter in Epic, we write a note, check the PDMP, we prescribe the medication electronically. And that's it. Our data from 2020 until last fall, we had about 632 calls, resulting in 468 new prescriptions. Some of them are repeat calls, people who didn't make it to their appointment, or the dose didn't work for them. Some people we didn't think we should prescribe buprenorphine to, so we did not. Average age was about 40, a little less than 40% female. Rhode Island is, I would say, a pretty Caucasian state. We have a slight overrepresentation of Black and Latinx folks in our caller population compared to our general population, but majority white, about 20% housing insecure, and we have this insured rate is equivalent to the insured rate in Rhode Island. A little bit over 97% of Rhode Islanders are insured, so similar amongst our callers. And then we have done like a kind of smaller evaluation, a preliminary evaluation of a smaller time period of the first year, which had 134 unique callers, 103 buprenorphine prescriptions, about 70% of individuals filled a subsequent prescription within 30 days. So they got to a maintenance treatment appointment after their initial telehealth appointment within 30 days. So this is how I kind of have my very rough schematic of treatment access and linkage and how telehealth fits into that. So the patient can go to the emergency department, or they can go to a clinic to initiate treatment. If they go to the emergency department can refer them to clinic, and they can have maintenance care in clinic. I realize it's very overly simplistic and not actually how life is. Now, telehealth, the individual can call the phone line and start treatment, and they can then set them up to the clinic. But or the emergency department can call someone can be seen in the emergency department, and they can follow up and telehealth. So one of the things we did in our system when we launched the hotline is we actually got the hotline number auto-populated on all of the discharge instructions. And we also have them on posters in the department. So we will get phone calls from people who had been in the emergency department, weren't ready to start treatment, but will call the phone line and say, I was thinking about it, or my family member said XYZ, and I want to start treatment. And then we can get them into care. The clinic, let's say a patient calls clinic and they set up an appointment. Clinic can't see them for 2 weeks. There's no treatment availability. Instead of that person not having access to medication, they can call the hotline. They'll tell them to call the hotline for a bridge prescription. We'll speak to them, get them a bridge prescription, and link them back to the clinic for follow-up maintenance care. And then kind of, the backup to all of these, if you call to talk to someone on the hotline and things do not seem well, or if they're in clinic and the person's really not doing well, you can always present to the emergency department, who can link people back to either the hotline or the clinic. And these kind of redundant, overlapping systems of care, I think, can really build a more robust safety net that can provide low barrier opportunities for people to engage in care when it works for them. I think one of the things about the phone line and the emergency department, a little bit less the emergency department, is that someone can reach you at a time of their maximum motivation. So they might not be motivated at the time of their ED, or if they go to the ED because they're motivated, but then they wait 7 hours and then they're not motivated anymore and they want to leave, because who wouldn't want to leave the emergency department after 7 hours, I guess. There is on-demand access care there too, but there's a lot of other systems issues. The phone provides a little bit more of on-demand care.
Now to review in closing, a
Oh,
social nurse
no.
medicine.
Sorry about that. So a few other things I just wanted to kind of say. Sorry, that old slide had a little audio on it. I apologize. Let me see. I don't think I can change that. I think it can be overwhelming to think about both policy and addressing health-related social needs and in ED interventions that we can do to try to address substance use disorders. I think the policy work is super important, and we should be engaged in that both individually and then on like professional society level. Policy advocacy is very important. And that is really more focused on drug laws, drug criminalization, and then like how we fund or do not fund our social services in our society, right? But we can develop programs and interventions that address health-related social needs, like the community health worker programs, or set up structures like either ED programs or low threshold tele-abuse programs that can try to minimize some of the barriers and address some of the equity issues to get people into care. You know, I know that you all have had like a significant experience at this at Penn, so you know I won't belabor some of these points. A lot of the models that we've looked to build in Rhode Island. I know you do a lot of really similar work at Penn that we've looked to for inspiration in Rhode Island, and I think and also nationwide. But so I'm really interested in people's thoughts and feedback and questions. I know we only have about like 12 minutes left, so I'll just close it there.
Thank you so much, Liz. And we'll open the floor. I should say that when we started our Care Connect Warm Line, we reached out to Liz and Rachel Whiteman on multiple occasions for some really detailed workflow questions. And our models are slightly different, but globally the same, providing important safety net access. And I think almost everyone on this call has either referred a patient or been supported in their clinical efforts by having patients being able to access the warm line in those, weekend pinches or patient discharged without a prescription or all those things that seem to happen. I will start with just one big question, maybe two big questions, but one is, as we've been able to show really robust success in a super cheap model of telehealth, why isn't the government coming to you and me and saying, we want to expand this to cover your state, to cover a region? We know that there aren't enough prescribers. We know that there are gaps in care. I mean, we have presented our data, which is very similar to yours. And I'm kind of amazed that there isn't somebody, there's so much federal funding for everything right now. It feels like we have the most efficient, effective safety net that could be implemented widely. I don't know, what is your take on why that isn't happening? I know the telehealth laws are just now becoming more established and written into law, but it still feels like people would have recognized or appreciated the safety net earlier as an expansion opportunity.
I totally agree. I mean, we have talked with people. I know Massachusetts, I'll talk federally second, but first stay with Massachusetts has thought about setting up a statewide line. I've spoken with their Department of Health folks about it, and then like Chicago, Department of Health in Chicago was like thinking about setting something up. I think you spoke with them too, yeah. And I know there were like different efforts in Pennsylvania. I think that some of it is, I think there's multiple things. I think one is there's the uncertainty what's going to happen with telehealth. I think that there is a lot of reluctance among federal agencies for the audio only component. SAMHSA, when I've spoken to them, have seemed really interested and supportive, and I've shared with them our data. I'm like, look at our data. They think this is a good thing. And I don't know if people have had a chance to see the new DEA regulations. I mean, they're certainly better than what we had before, but they're more restrictive than what we have now. So I do think that some of it is maybe reluctance on the part of the DEA. I think that there are some forces that maybe aren't super keen on it in addiction. That's some of the impression I've gotten when I've tried to speak to legislators about the Treats Act, the previous Treats Act, and adding in a component that allows for audio only. I mean, I find it also kind of interesting because, a lot of the people who are in states that have like large rural populations with poor broadband access. So it wouldn't really serve their constituency to really improve access in any kind of meaningful way. So
If they had the non-audio only.
yeah, if they had to require a video component.
Yeah.
But it seemed when I've talked to individuals that there's, maybe ASAM wasn't on board with that at first. Maybe they've changed now their perspective about that. But I know that was a big component of it for a while.
Thanks. It's helpful to hear your thoughts.
I'm talking that United CTN has a telemedicine group. I'm talking to them tomorrow. I'm very interested to hear. I didn't even know they had a telemedicine group, but I feel like that would be like one avenue to try to support more widespread adoption of the model.
Interesting. Yeah, I mean, at a state level, you could, almost think of, looking at getting people into treatment in a place that has a telehealth backup and retention versus, places that don't have it. But I guess my bigger question too was just, given that you are really such a policy expert and we appreciate your advocacy in so many frontiers, is there a policy that you would long for that would make significant? I mean, so the X waiver's gone, right? That was a big one. What's the next thing that we need to kind of advocate for to make sweeping change in that same venue of treatment access?
Well, I guess a few things. I think the bridge model, California Bridges model, is really notable for several reasons, but they've been able to expand treatment access and initiation and change practice in a wide variety, widely diverse hospitals, rural, urban, academic, community, and like how they've done that is through the substance use navigators.
Mm-hmm.
Like those individuals, they gave hospitals money, they hired substance use navigators, and they set a policy expectation, not quite the same as Rhode Island's levels of care, but they set some policy expectations around post overdose care that I think allowed for that model to affect change. So I think you need to have CMS reimbursable community health worker peer recovery services in like a really real way, like not just like a token reimbursement, but like, so it would incentivize hospitals to hire and support and maintain this workforce. And like, also not just like, I mean, ideally, right, there's like a workforce that can have opportunities for career advancement, promotion, et cetera, as like a career pathway for folks. And they have to be well supported because folks need a lot of support, I think. They're very hard jobs. And I do think some type of quality incentivization, as this is how we affect change in our healthcare system, needs to be put into place, because many hospitals are not going to do this or provide this unless the incentivizations are aligned to make them do it. And I think some of that is financial, some of that might not be financial, but I think getting those things aligned to be able to do that will help with implementation. Getting rid of the waiver is great, but it's an implementation problem. And it was even an implementation problem before we got rid of the waiver, because you had a lot of people wavered but not prescribing. So that's not really like a discrete policy thing, but I think that's where we need to put our energies.
That's great. Thank you. I see Maggie.
Hi, Maggie.
Hi, Liz.
Nice
Thank
to see
you.
you.
So nice to see you, and amazing work. I was kind of going to ask some similar questions to Jean Marie. We spent a lot of time together, but so we have the same thoughts. But I guess I wanted to ask, like, maybe a little more concretely, like, maybe I missed this, but how are your services? You said your services are funded partly by like a SAMHSA grant, but are you exploring models to, like, what's your payment look like for your?
So the community health worker program was initially a grant through the Department of Health, and that has now been adopted by the hospital. So they're now fully funded under the Department of Social Work for the community health worker program. The hotline was our Department of Behavioral Health got a SAMHSA COVID emergency grant, and we got funding through that. But we are now, at least they say, the plan was for that opioid settlement money to go into supporting the hotline. And that's like a decade of funding. Ideally, we would be a line item on the state budget, but settlement funds is quite a good start to kind of figure out more sustainable funding. Because that I think that they don't bill. So it's what I mean, some people seem to pay for their medication when they go pick it up. There's obviously you could open that is something that's possible to do is to do, especially in a place with such a high such a high proportion of folks who are uninsured. But that is the current sustainability plan for the hotline, is that the state wanted to put it on the settlement funds.
Oh, that's cool. I mean, I think, yeah, we bill for the provider visits, but all the hard work that's done by the navigators is not available. And that's the secret sauce of the whole thing. So it's finding models that, I mean, I think your point earlier about just better support for these types of peer support models, like actual reimbursement and actual advancements, so critical.
Yeah. And, I had to say, the salary of the community health workers, that's been one of the hugest issues we've had with RHR, is trying to get salary increases for people, because we want to retain and hire good people, and they're doing really hard work and they should be compensated for that hard work. But that's been something institutionally that's been very challenging. Because they're well, they don't have a bachelor's degree. And it's but we're not hiring them for their bachelor's degree. There is a whole wealth of other experience that we are hiring them for. And that is what they're utilizing in their job every day. So it's been a very interesting, the institutional culture and expectations is very different than the, what we're introducing in the program, and rectifying and bridging that has been a ongoing challenge, I would say.
That's awesome. I was going to ask just one really last quick question about your role in the Rhode Island Health Department. Was that a job that was already there that you filled, or did you created that? Because it seems like a tremendous extra added value, both for the health department and for the ability to have an insider understand, sort of the domains of emergency department treatment access, et cetera. So tell us a little.
That happened kind of organically. So I used to be the assistant medical director for the drug overdose prevention program at Rhode Island Hospital Department of Health. I had done a policy placement there during NCSP and worked on their levels of care project. And then when I was coming back, the director said, well, let's figure out a role for you. That was one of the incentives for me to go back to Rhode Island. I was we could figure out a role for you at the Department of Health. I was that's perfect. I would love to continue to do work there. So we created this assistant medical directorship kind of together. The medical director of the program was also, he was the head of the medical board and the PDMP, and Dr. McDonald was doing so many different things. And so it was great to work with him, and then also just to be able to just work on the overdose prevention program. So then we set up a contract and just kind of set it up as a consultant type of agreement, but that's kind of how I carved my role out there. But it was very useful. I mean, just in terms of being able to feed back between the two settings. Because even though Rhode Island is very small and everyone knows each other, it's amazing the amount of miscommunications or that can occur. I felt very lucky. I thought that was a very special role and opportunity.
Yeah, it makes sense. I mean, we have a little bit of that, but not quite the same. Would be really helpful, I think, especially when you think about, some of these projects that have made a big difference, but are not always, followed as closely by the health department. So, well, I want to thank you sincerely for coming. I know you've been busy in the east to west coast transition. I loved hearing earlier a little bit about what substance use looks differently out there, and I know we'll be collaborating on things in the future. So thank you again, and I know that our group and policy gurus here are always reading your work and learning from it. So thank you.